Thrombosed synthetic dialysis grafts are frequently referred to the interventional radiologist. Now, Aero International brings you a new, more effective treatment to offer your dialysis patients. The Aero Trerotola Percutaneous Thrombolytic Device, or PTD. The 5 French PTD catheter, in conjunction with the rotator unit, mechanically declots synthetic grafts without the need for thrombolytic agents. The Aero PTD has many advantages over other percutaneous devices. The PTD is designed for ease of use. The catheter smoothly slips into the rotator unit. The fragmentation basket is deployed with a simple, controlled motion. And the on-off switch deactivates when finger pressure is removed. Another advantage of the Aero PTD is its lower associated costs when compared to pulse spray techniques. Thrombolytic drugs are not required. Without thrombolytic drugs, catheters or sheaths can be pulled much sooner, allowing earlier transfer from the radiology suite. Perhaps the greatest advantage of the Aero PTD is the fast and effective removal of thrombus from the dialysis graft. The nickel titanium basket expands to fit the full diameter of the graft, gently removing residual thrombus from the graft wall. We will now review the suggested procedure. Flush the catheter with saline solution. Attach the PTD catheter to the rotator drive unit by placing the catheter hub assembly into the front of the drive unit. Slide the entire catheter hub assembly into the channel until the cable stop reaches the end. Turn the cable stop arm into the cable stop slot of the drive unit. The cable stop will stay locked in this position for the duration of the procedure. Slide the side arm of the hemostasis hub forward so the outer sheath covers and compresses the fragmentation basket. The basket's plastic tip is soft and flexible. When inserting the device into the access sheath, you may choose to cover the catheter tip with the outer sheath. Alternately, if the tip folds onto itself as it enters the sheath valve, pulling the catheter back slightly will allow the tip to unfold within the hub for proper insertion. Turn and lock the sidearm into the compression slot to prevent the outer sheath from moving. This is the compressed position, which is used to insert and position the catheter within the graft. To deploy the fragmentation basket, move it to the center deployment slot. Note that as the outer sheath is pulled back, the basket remains stationary while being deployed. With the fragmentation basket in the deployed position, depress the on-off switch. The fragmentation basket should spin while the switch is depressed. Spinning should stop as soon as the switch is released. After prepping and draping the patient, perform a skin wheel at the anticipated venous sheath puncture site. An introducer sheath is directed toward the venous anastomosis. A larger sheath may be required when additional procedures such as angioplasty or stent placement are performed. Under fluoroscopy, the native vein is assessed for existing central and venous outflow stenoses. If fluoroscopic assessment shows venous outflow stenosis more than 10 centimeters long, untreatable central venous stenosis or occlusions, or any large pseudoaneurysm, the treatment of the graft with PTD should be reevaluated and alternate treatments considered. In the rare instances in which there is no venous outflow stenosis, place a blood pressure cuff or tourniquet on the arm just above the venous anastomosis. At this time, administer 3,000 units of heparin intravenously. With the PTD in the compressed position, insert the catheter through the venous sheath into the venous limb of the graft. Advance the flexible tip of the fragmentation basket up to the venous anastomosis. Do not advance beyond the anastomosis. Expose the fragmentation basket from the outer sheath by sliding the sidearm from the compressed to the deployed position and activate the rotator. Slowly withdraw the rotating fragmentation basket along the graft to break up the clot. When the basket reaches the tip of the access sheath, turn off the rotator. Place the device into the compressed position. Advance the tip to the venous anastomosis in preparation for repeating the procedure. When the 2 passes are complete, remove the device. Aspirate approximately 5 cc's of the homogenized clot via the venous sheath and discard the aspirate. Manually remove any accumulated fibrin from the fragmentation basket. Inject a small amount of contrast to ensure that adequate thrombolysis of the venous limb has been accomplished. To prevent possible arterial embolization, do not over-inject with contrast. Prepare the arterial sheath insertion site by performing a skin wheel and insert the introducer sheath toward the arterial anastomosis. Do not allow the arterial and venous sheaths to overlap. With the fragmentation basket in the compressed position, insert the catheter into the arterial limb of the graft. Advance the tip of the fragmentation basket up to the arterial anastomosis. Do not advance beyond the anastomosis. Expose the fragmentation basket and activate the rotator unit. Slowly withdraw the rotating fragmentation basket along the graft to break up the clot. When the basket reaches the tip of the access sheath, place the device in the compressed position. Advance the tip to the arterial anastomosis and repeat the process. When the 2 passes have been completed, remove the device from the sheath in the compressed position. Manually remove any accumulated fibrin from the fragmentation basket. Pass an appropriate balloon occlusion catheter through the arterial sheath and carefully feed past the arterial anastomosis of the graft. Inflate the balloon and pull the arterial plug into the middle of the graft. Deflate and remove the balloon catheter. Using the arterial sheath, insert the PTD in the compressed position to the arterial plug. Deploy the fragmentation basket. Activate the rotator to break up the arterial plug. Place the device in the compressed position and remove from the sheath. Aspirate approximately 10 cc's of homogenized clot from the arterial sheath and discard the aspirate. Inject contrast to assess the degree of thrombus removal. Treat any residual thrombus using the PTD via either the venous or the arterial sheath as needed. If a blood pressure cuff or tourniquet was used, deflate the cuff and remove it. When thrombolysis is complete, any underlying disease or stenosis should be further assessed by fistulogram. Remove both sheaths from the graft. Inspect the sheaths to be sure the entire length has been removed. Hemostasis of both sites should be achieved according to hospital protocol. The patient may now be transferred for dialysis.
Dr. Scott Trerotola, inventor of the Trerotola PTD, will now provide a review of solutions to potential problems which might be encountered during use of the PTD. What should be done in the event of device breakage?
We have identified 2 potential sites for breakage of the PTD. The first is for the cable to break at the hub, and the second is for the basket to break. There are 2 methods to avoid cable breakage. Breakage at the hub can be prevented by not gripping the cable too tightly during activation of the device. The second means of preventing undue stress on the cable is to hold it in a straight line during use. Breakage of the basket can occur either at its attachment to the cable or close to the tip. The only breakage we've actually seen is at the attachment to the cable. We believe this occurs because of prolonged activation in a curved configuration, especially when treating the apex of a loop graft. The way to avoid this is to limit device activation to a total of 3 minutes for the entire procedure in a curved configuration. The way of handling a basket breakage depends on whether the breakage occurs at the tip or close to the cable. If it occurs at the tip, one can simply pull the device out through the introducer sheath and discard it. If breakage occurs close to the cable attachment, pulling backwards on the device may cause the broken wire to pierce the graft and make device removal difficult. In order to remove a device in this situation, approach the basket through the opposite sheath. Using a snare, grasp the tip of the basket, pull the basket out through the opposing sheath, and it should come out easily because the wire will be facing in the correct direction. At this point, one can manually guide the wire into the catheter and pull the device back through both sheaths and discard the damaged device.
What problems might a practitioner encounter relative to the access sheaths?
There are 3 possible sheath problems which may occur. First, the sheath may become dislodged during the procedure, in which case one should simply advance the sheath back over the PTD catheter, thus restoring access. The theoretical possibility exists for the device to become entangled in the opposing sheath during the treatment of clot which is near that sheath. If this occurs, while keeping the catheter as straight as possible, one should simply turn the rotator off, move the basket back and forth until it becomes disentangled from the sheath, and remove it. Another sheath-related problem when treating clots in and around the opposing sheath entry site is that one may find it difficult to treat that clot because the sheath is in the way. The way we handle that is to remove the opposing sheath over a guide wire, use the PTD to treat the clot in that area, and then rapidly re-advance the sheath over the guide wire. This is almost always successful.
How do you treat a clot that adheres to the graft wall?
The PTD is usually successful in removing all the clot in the graft with only a few passes. Occasionally, adherent clot can occur. When it does occur, we find it useful to use the device in a back and forth or toothbrushing motion to get the adherent clot off the wall of the graft.
Some practitioners have experienced reclotting during a long procedure. What recommendations can you make to address this problem?
During a prolonged procedure, one may encounter rethrombosis of the graft. If this occurs, assess the patient's anticoagulation status by checking an activated clotting time. If the activated clotting time has fallen below 200 seconds, one should administer additional intravenous heparin.
How do you recommend treating a clot that gets caught in the device?
Occasionally, clot can get caught in the basket and make it appear as though the device is incapable of treating the clot. While keeping the catheter in a straight line, one can pull the activated basket into the catheter or pull the catheter and activated basket into the introducer sheath. The clot will be effectively macerated as the basket is compressed into the catheter as it exits the introducer sheath.
How can difficult deployment of the basket be overcome?
Occasionally, difficulty can be encountered when deploying the device, especially when working around the curve of a forearm loop graft. This can be prevented by flushing during and between passes. However, even with adequate flushing, difficulty in deployment occasionally will be encountered. If this occurs while keeping the catheter in a straight line, one should activate and deactivate the rotator in short bursts while retracting the catheter, which should allow the basket to be deployed without difficulty. Keeping the catheter as straight as possible helps avoid the wrapping up that can occur when the catheter is in a loop when the device is activated. This wrapping up of the cable does not occur unless the basket is unable to spin freely.
What methods should be employed when the device is difficult to retract into the catheter?
Fibrin buildup on the device can cause difficulty in retracting the catheter over the basket or in removing the device from the sheath. This can be prevented by keeping the device clean between uses by carefully picking the fibrin off the basket. In addition, if one cannot retract the catheter over the device, simply removing the device from the introducer sheath while fully deployed is an acceptable alternative.
Please discuss methods to prevent arterial embolization.
Arterial embolization is a potential complication of any percutaneous or surgical thrombolytic procedure. Arterial embolization can be avoided by not over-injecting contrast into the graft while it is still clotted. This is probably the single most important preventive measure. In addition, one must be careful when deploying the PTD near the arterial anastomosis in order to prevent the basket from dislodging clot into the artery. The PTD should be deployed by retracting the catheter over the basket, not by pushing the basket forward. This is similar to deploying an IVC filter. Gripping the catheter of the device too tightly during deployment will cause the basket to move forward rather than the catheter retracting to expose the basket. The treatment of arterial embolization from dialysis graft declotting has evolved somewhat over the past several years. Asymptomatic emboli may not need to be treated, especially if that treatment involves using urokinase or surgical thrombectomy. However, there are several simple techniques for treating symptomatic and asymptomatic emboli with little or no additional risk or cost to the patient. The first of these is the backbleeding technique. Using this simple technique, one places a wedge balloon or Fogarty catheter into the brachial artery just above the arterial anastomosis. The balloon is inflated and the patient is asked to exercise their hand for about 1 minute. After this time, the balloon is deflated and repeat fistulography is performed. In our experience, the vast majority of patients will have the complete resolution of the emboli when treated with this simple technique alone. This technique does rely on a patent graft for success. If backbleeding fails, another simple technique is to use a wedge balloon over an 0.25-inch guide wire. We usually use a glide wire for this. The balloon is passed beyond the embolus, inflated and then pulled back over the wire, which usually dislodges the clot back into the graft, thereby treating the embolus. One potential problem with this is fragmentation of the embolus. Therefore, we prefer to use the backbleeding technique first. A third fairly simple technique for treating arterial emboli is thromboaspiration. This requires the use of a larger catheter, such as a guiding catheter. If thromboaspiration, backbleeding, and balloon mobilization fail in an asymptomatic patient, we believe that no further treatment should be rendered. This has been published in the Journal of Vascular and Interventional Radiology in 1997.
Should practitioners be concerned if the treated clot cannot be aspirated after treatment of the venous limb?
In preclinical evaluation of the PTD, we found that the most effective use of the device was to create a slurry and then aspirate it from the graft. Occasionally, especially after treating the venous limb of the graft first, this slurry cannot be aspirated simply because one is still working within a closed system. That is, the venous outflow stenosis is still present and the arterial inflow is still occluded. Because of this, aspiration of clot may not be possible until the arterial limb of the graft is treated and inflow is restored. At that time, aspiration will be possible.
Does the speed with which each pass is made influence the effectiveness of the clot maceration?
If passes are made at an extremely fast pace, the clot may not be adequately treated. Pulling the rotating device through the graft at a slower rate will result in adequate clot maceration.
The basket can be difficult to position around a tortuous curve. What techniques can be used to overcome this problem?
Because the current version of the PTD does not go over a wire, occasionally one may find difficulty in passing the device around very tortuous grafts or through grafts with large pseudoaneurysms. When this occurs, I have found it helpful to use a hemostat or other device to alter the shape of the graft slightly, which usually allows the PTD to pass without difficulty. In extreme cases, the inner basket and cable assembly can be removed from the catheter and the catheter passed over a guide wire to the desired location. Then the inner cable and basket assembly can be replaced through the catheter and the PTD used. The cable should be fed through in small bites to avoid kinking the cable.
What if the device is inadvertently introduced into the native vein and trapped by venous spasm?
If you inadvertently place the device into the native vessel and find you cannot move the catheter into or out of the vessel, give nitroglycerin in 100 microgram aliquots by direct IV push. Given an adequate amount of time and an appropriate dose of nitroglycerin, the vessel will relax and the device can be removed.